Once again, good morning, students. We'll be looking at chapter 36, Pediatric Clients. And before we look at pediatric clients, what we do is we have to cover some theories dealing with domains of functioning, basically. So we have different theories. We have the temperament theory, moral development theory, cognitive theory, and attachment theory. Okay, so these are the four theories that we're going to look at. And first we're going to look at temperament theory. Okay, so what is temperament? Temperament basically is your mental, your physical, and emotional traits, who you are as a person, your natural disposition, okay? And it basically says, this is who I am. This is how I behave. That's what temperament does. It basically motivates you to be the person that you are. That's what pushes you, in a sense, to be that person that you are. Your temperament, okay? So your temperament says, am I an easy person? Am I a difficult person? Am I slow to warm up to? Or am I a friendly person? Am I honest? Do I lie? Do I cheat? All of these things are part of your temperament and your makeup, okay? And basically, that is what temperament is. Now, there are different types of therapy that we could look at in the area of temperament. You look at temperament theory, etc. But usually, the worst case scenario, you would have a child with a negative emotionality. When we talk about a negative emotionality, that's kind of like maybe not the best temperament to have. So that child will definitely have a meltdown really easy. This is the kind of child that you take to daycare, right? So the child goes, the mother takes him to daycare, and then he doesn't want to separate from the mother, and he goes into a corner and starts crying because the mother has to, after the mother leaves, rather. And then if another child tries to come and befriend the child, this child is crying and then strikes out at the other child who is just trying to comfort the child, and he will not receive comfort. This has to do a lot with the negative emotionality, and these are kids that really have meltdowns for no apparent reason. And we'll look at that a little bit more. So that's temperament theory. Now let's look at Kohlberg's stages of moral development. And so we need to look at how morals develop, ethicals and morals, basically what's right, what's wrong, and why we do the things we choose to do, whether they're right or wrong. So let's look at this. So moral decisions are based on compliance with social norms in order to preserve social order. Basically, that's why we do what we're supposed to do, because we want to maintain social order. Now, Kohlberg said in level 1, which is called the pre-conventional level, people make judgments based solely on their own needs, their internal needs. So in stage 1, in pre-conventional, we have punishment and obedience, okay, orientation. So in punishment and obedience orientation, we basically do the right thing because we don't want to get punished. We see a picture of this in the Germans during World War II, where a lot of Germans were asked to do atrocious things. They kill people, especially kill Jews, put them in concentration camps, gas babies, gas women, shoot pregnant women in the head, etc. Just horrible, horrible, murderous things. And why did they do it? Because they worked, Kohlberg would say, because they worked from a pre-conventional level, and at stage 1, basically, they didn't want to get punished. They didn't want to get killed. They didn't want to get murdered. So they did this. Stage 2 is personal reward orientation. So basically, in this stage, Kohlberg says that we do the right thing because we want to get rewarded, you know. And you do something for me, I'll do something for you. You do right by me, I'll do right by you. So it's personal gain in this level 1, stage 2. Level 2 is conventional. And in level 2, people consider society's expectations and laws when making moral decisions. Okay? So what are we talking about? We're talking about, for example, in stage 3, where is the good boy, nice girl orientation. So basically what we have is a conformity, and basic conformity because that person wants to be looked at as a good person. That's a good girl. That's a good boy. And so this is why we do the right thing. In stage 4 is law and order orientation. And basically we do the right thing here because we respect those rules that are set forth by the laws. And we follow rules and we don't break rules. These people will stick to rules. They'll hardly ever break rules because they are at stage 4. No one is really ever remains in one stage, but we progress or we grow into each stage. Okay? And so at this stage we can see that respect for law and order, even religious order, so that the Pope, whatever he says, is what is law, and that is gospel, whatever the Pope says. So at stage 4, we could see this happening, this kind of perception and mentality that Pope is like a god. All right, so level 3 is post-conventional. And at level 3, we see people basing judgments on abstract personal principles which are not necessarily defined by societal laws. So these are not defined necessarily by what laws we see in society, judicial laws or other. So in stage 5, level 3, we see social contract orientation. All right. So what does this mean? For example, let's look at the Constitution. So the Constitution says that all men are created free, and we should not impinge on the freedom of others. And as much as some people do, basically what an individual is saying at this point is there is freedom for everyone and equality, that all men are created equal. So we look at that basically not from judicial laws that we have already set, but by our Constitution. And sometimes even an innate, inbred sense that we are really, truly all the same, okay, as human beings. Stage 6 is universal ethical principle orientation. And this is where we believe that God is understood to say what is right. Whatever is moral comes from God. It comes from the Bible or from some universal entity, that the universe is created by something, and that something is good, and we should then make good decisions because of it. Okay, so that was Kohlberg's. Let's look at cognitive developmental theory. Cognitive developmental theory, we have Jean Piaget, 1896, and basically what he looked at was he wanted to see how organisms adapt to their environment. This is called adaptive intelligence. And under adaptive intelligence, we have two components. We have the process of coming to know and the stages that we move through as we gradually acquire the ability to know. All right. So stage one, let's look at an infant, for example, a baby. So that infant, how does an infant learn about its environment? Well, Piaget said that at stage one, that infant uses sensory motor perceptions. Okay, so it senses with its five senses. It sees, it hears, it feels with its hands and its legs, it crawls, and it tastes with its mouth. Okay, so this is how it comes to know the world. It'll grab something and stick it in its mouth and say, wow, this is rather smooth, and then it'll kind of suck on it or whatever, and then throw it, and then it'll touch different things, and this feels hard and raspy. This feels jagged. So it learns about the environment through touching. A cat is furry, but be careful with the cat, because then the cat could scratch you. It has like some kind of objects on its paws that it scratches you with. So the child gets knowledge of the world via physical interaction and what it experiences. Okay. In the next stage is the pre-operational stage. In this stage, in this stage, intelligence or getting to know about the world is received through use of symbols. Okay, well, it's not actually received through use of symbols, but through the use of symbols, it learns about the world. For example, when mother says, you know, do you want water? Water, and it shows the baby water. This is like would be a toddler, etc., and about 2 years old. The baby then puts the two together. It symbolizes the word water is that liquid which helps me when I'm kind of thirsty and I need something to drink, or food. And she says food. The child then learns cow, sees a picture of a cow, and then it uses symbols to then memorize and put together intelligence about the world. Okay, this is also the stage where the child will play alongside of another child at about 2 years old, because children are usually very egocentric at these times. So what they do is what's called parallel play. They'll play right by the child, but they won't play with the child. So they have like a social distancing, like sort of like we have. Okay, we're regressing. All right, so that's second stage. In the third stage, we see concrete operational. Okay, the concrete operational stage. Intelligence is gotten through logical and systematic manipulation of symbols related to concrete objects. So what we're talking about here is, for example, that you take the child to, this is usually around the early adolescence. Okay, so maybe you might take the child out to drive, and it notices, you teach a child, when you turn the wheel to the right, the car is going to go to the right. When you turn it to the left, the car is going to go to the left. So what is this? These are concrete operations, right? We're doing something concrete, something tangible. You could see it, and you're moving the car to the right or to the left. And so you need to logically think it through. And then the symbol is the turn moves the car this way. The left, if you move the steering wheel to the left, it moves it to the left. If you press on the brake, it stops the car. If you press the gas, it accelerates the car. All of this is very concrete and operational. You're operating in the concrete mode, okay? Let's go to the next slide. Yes, slide number 7. Stages continue. Number 4 is the formal operational stage. And this is where the child learns or picks up the ability to abstract, okay, in abstract manners. And that's approximately around 12 years old. For example, can you abstract this? If Kelly is taller than Allie, and Allie is taller than Joe, who is the tallest? Okay, so if Kelly is taller than Allie, and Allie is taller than Joe, who is the tallest? Think about it for a minute. Right, right, Kelly. Exactly. Okay, so now in concrete operational or are usually carried out uh, on things where we head back to concrete operational stage 3 is carried out on things, whereas formal operations are carried out on ideas. For example, playing a game of chess where we consider the consequences of what can happen if you do, what if I do this, then this might happen. So that is kind of, it's abstract, but it's also carrying out these formal operations, right, on ideas more than on objects, like moving a car, because chess can be very abstract. So that was again, that was Piaget, and just a little bit. If you want to learn more about him, you could put them on YouTube. Primary attachment figures. What are we talking about? Well, children attach to their family members, right? They become bonded with them. So the theorist is John Bowlby. And so basically what he said was that infants attach to their caregiver because their caregiver cares for them by the 6th month. All right, the child is with the mother, father for 6 months, and whoever's the primary caregiver, eventually that child will bond or connect with that child, especially if that person is giving the child emotional security, physical care, and stimulating the child. Now, Bowlby came out with his theory based on Lawrence's theory, who studied the imprinting of baby geese. So Lawrence worked with geese, and he saw that when the geese was born, the first thing that it saw when it emerged into this world was what it imprinted on, what it considered to be its parent or caregiver was the first thing it saw. If it saw a dog, that was mommy. If it saw you, you became mommy, and it would follow you around as if you were the mother and would look to you for attention, nurturing, physical care, and stimulation. So basically, true affection develops, which is supported by new cognitive and emotional capacities and a history of consistent, sensitive, responsive parental care. That's how you get true affections. Of course, that imprinting is all, is all secondary to also the care that you give a human child. There is a little video that you could watch at your leisure. And let's look at protective factors increasing a child's resistance to stress. Personality traits such as positive self-image will help them when it comes to coping under stress and dealing with life's tumultuous situations. Family cohesion and absence of discord, families together, they're not breaking apart. support from significant others, anybody, uncles, other people that support, and a positive relationship with at least one parent. They can have then they can resist stress. Uh, Children may experience psychiatric challenges, which is true. And I'm having a little setback here. Okay, so next slide. Risk factors for psychiatric disorders, children and adolescents. What's a risk factor? Family with a history of mental illness. That's a risk factor. Immature development of the brain. They didn't develop correctly. Brain abnormalities. Family problems and dysfunctional families. Poverty. Mentally ill or drug abusing parents. All of these are risk factors for psychiatric disorders. Teen parents. Maybe the parent of the child was a teen. That's a risk factor. Abuse. Sexually abused, physically abused, that child may develop a psychiatric disorder. Discrimination against the child based on race, creed, or color. Chronic parental conflicts and divorced parents. Parents are always fighting, they finally get a divorce. Chronic illness or disability. Excuse me. Chronic illness just doesn't have to be the parents. Could be a sibling that's there, and that sibling might be disabled and gets a lot of the attention. So that child may not get the attention and may wind up with a psychiatric disorder. Families can definitely influence infants with difficult temperaments. Doesn't matter how bad the temperament is, especially if it's negative emotionality, as we discussed before, that child that has a meltdown. That's the child that always is crying. No matter what you do, that child cries. You give it the bottle, it cries. It's just a very difficult baby. Interventions for children with psychiatric disorders. Prevention and early identification. We have to consider that all development, it must be evaluated according to the developmental norms. But that norms, it could be around a certain period. The child takes his first steps at 9 to 12 months. If it happens at 13, 14 months, you don't really, get too bent out of shape because of it. If they're supposed to be walking at 14 or 15 months, it's possible that they might walk at 16 or 17 months. Okay, so it's not hard and fast, but we look for those developmental milestones. Now, if all areas are backlogged backwards, they don't develop any area, then there might be a problem. In a lot of areas, then we have a problem. Psychosocial modalities, individual therapies, brief psychotherapy, play therapy, and family therapy are all interventions that can be used. Play therapy because children love to play. Risk factors for pediatric suicide. A family history of depression. If you had a family history of suicide, that's a risk factor. Physical or sexual abuse, the child being physically or sexually abused. Exposed to violence upon themselves or witnessing the violence of one of the parents. Okay? Impulsivity, if that child is prone to be very impulsive, that's another one that might another risk factor that might predict suicidality. Loss of a loved one before the age of 12. Violent behavior, we talked about that. That child being violent. Diminished sense of connection to family and increased family pressures. All right, so we're going to look at some disruptive behavior disorders, okay? Um, those are the primary ones that we're going to look at, because when we look at other disorders like anxiety disorders, etc., a lot of those are similar to adult disorders. Okay, so we'll just primarily focus on the pediatric disorders, the disruptive behavior disorders. Okay, so we have ADHD, we have disruptive behaviors and oppositional defiant disorder, conduct disorder, and adjustment disorder. And we'll look at each one. Those are the only four we're going to look at. Uh, Anxiety disorders, okay? OCD, separation anxiety disorder, phobias, social anxiety disorders, generalized anxiety disorders, PTSD. Children can have those too, okay? And they're, like as I said, they're similar to adults. Mood disorders like depression and bipolar, that could also be seen. Uh, autism spectrum disorders like autism, or they call it now intellectual intelligence deficits, okay, and Asperger's, eating disorders, and substance abuse all could be seen in pediatrics. So first, let's look at attention deficit disorder. So what is ADHD? Attention deficit, of course, so they can't keep the attention. They can't focus on something. Hyperactivity disorder. So they're hyperactive, they can't focus on anything, okay? So basically that is it. They're very impulsive, hyperactive, poor attention, okay? And usually this is caused by either genetics, they usually inherit this, and the environment contributes a lot to it also. So what will we see? Well, we're going to see a child that can't focus, is all over the place, can't follow directions, is constantly moving, hyperactive, okay? Attention deficit, can't focus on anything, can't concentrate. Hyperactivity is constantly moving, can't sit still in the chair, gets up, runs to the back, starts climbing on things, and basically talks excessively, constantly talking, and takes risks, will get on tables, will jump on the table because they can do it. All right, may run out into traffic, all of a sudden just run out, and there's traffic moving, cars are moving, and they'll just run. Another detail is that they lose things. They're not focused, so they lose things. You give the child a backpack, you give them gloves, maybe because it's cold, and a scarf and a hat. The child will come back. Maybe you say, "Where's your gloves and your hat?" I don't know. Probably left them on the bus. Or they'll come back and, "Where's your backpack?" I don't know. When'd you have it last? In school. Okay, so that's where they left it, in school. Okay, so that is it. This disorder usually continues in adulthood for at least 50% of the diagnosed youths into adulthood, and then it usually dissipates by the time they get into adulthood. But another 50%, it stays with them. What do we do for that? Well, Ritalin and Adderall are the two drugs of choice. These are amphetamines and mixed amphetamines. Ritalin, methylphenidate, and Adderall is the mixed amphetamine. We could also use Strattera, which is a serotonin norepinephrine reuptake inhibitor. That's non-narcotic, but the Ritalin and the Adderall are controlled substances, okay, and they're on the controlled list, okay, FDA controlled. They are stimulants. And the Ritalin, the mechanism of action is unknown, but it does help to increase the child's attention and to decrease some of the hyperactivity, all right? And it improves learning for the clients with ADHD. the worst side effects is that the child doesn't want to eat. They don't eat. It decreases appetite. Okay, and of course, because it's a controlled substance, individual can develop a tolerance to it. So we need to look out for that. Let's go to disruptive behavioral oppositional defiant disorder. Okay, so that's ODD. Okay, in this one, we find this child to be very negativistic and defiant. That's why it's called oppositional defiant disorder. The child is oppositional. He opposes adults and authority, and is defiant, defies authority. Okay, very stubborn and resistant to directions, and is unwilling to negotiate. You try to say, well, if you do this, you'll get this. They don't care. They don't care. They just want to be defiant, and that's whether it is. They test limits, meaning whatever. If you say don't do this, they'll go ahead and they'll do it. They argue. They ignore rules. And they won't accept any responsibility. If you make them respond, why did you do that? I didn't do that. You made me do it. You made me do it because you said I couldn't go to watch TV, so I went and I did this instead. Okay, so they justify their own behaviors. Okay. They'll blame it on you. It's your fault. They are directly hostile with adults and with peers. Now, how do we treat these kids? Behavior modification, family therapy. Got to get the communication going between the parent and the child, because that parent is so frustrated with this child, it wants to just take the child and strangle it. And you would want to reinforce any good that this child does. And when he does the right thing, you reinforce it. You encourage that child to repeat it. Okay, those desired behaviors, because you have to validate something, because you just want to take the child and stick it in the toilet or something. I get it. I get it. But we can't do that. We love our kids. All right. Next one is conduct disorder. All right, so with conduct disorder, we see a child that is manageable at home, okay? In the house, you can see this child complies maybe with what is done. May have some spots where they'll become a little bit of a pain in the neck, but then this is the way children are. But in the community, when they go out to school or they go out into the community, is when they become very disruptive, okay? The key point with this is that one key point is that children, a childhood onset rather, is more severe than an adolescent onset. All right, so if it comes on in childhood, it lasts for a while, and sometimes it just gets worse. If it's an onset in adolescence rather, then it's more, treatable, you could say. So, what's the important features that we see with these kids? Well, these kids lack empathy. They can't feel for anybody else. They lack guilt. They don't really feel guilty about what they do. They blame others. So, in a sense, they justify their behaviors by blaming their actions on other people. Like, well, he made me do that. Why'd you push him down the stairs? He broke his arm. Well, he was bothering me, meaning he deserved to be pushed down the stairs and have his arm broken and almost kill him. They perform risk-taking behaviors. They'll drink. These kids, you could have a 8, 10-year-old drinking, smoking. They'll use illicit drugs. They'll experiment with sex. They'll participate in crimes. They'll be cruel to animals. They'll set fires. They'll destroy property. And they'll steal. What does that sound like? That sounds like a criminal, somebody that belongs in jail. Well, a lot of these kids wind up in jail. when they get older. If they don't grow out of it, if they don't get the help that they need, they wind up going to jail. So a lot of sociopaths had conduct disorder when they were kids. Okay, and I had a boy, a young boy, was 10 years old. He had conduct disorder. He was being treated, thank God. He was being treated with mood stabilizer, and he was also getting a little Haldol, which was helping. And that's the only thing that really helped this child, because this child had, he could be really mean with his sister, and thank God he hadn't hurt the sister up until this point, but sometimes, you know, he was close to it, on the edge of hurting his sister, and he was cruel to animals. He threw a rock at a young man and cracked the front of his head with the rock, and the kid had to get stitches. He was angry with his mother at one point, and he took some matches and started playing with the matches at the side of the house, and the house caught fire. They had to come and turn the fire off because the house almost burned down. This is the kind of children that we're looking at when we look at conduct disorder. What is the treatment for these patients? Well, behavioral therapy techniques. But with conduct disorder, you really have to watch when they start escalating and they become aggressive, because they will act out aggressively and they can hurt someone. Okay? So you have to intervene. If they're in-house or at home, you have to teach the parents. If this child starts getting aggressive, you need to intervene. So antipsychotics, you're surprised, but antipsychotics have to be used. And mood stabilizers like valproic acid, Depakote, okay, and lithium. Adjustment disorders. Okay, so when we look at adjustment disorders, we're talking about when something happens, something happens to this child, and within 3 months of whatever traumatic event, something happening, an identifiable stressor, some stressor causes this child to then regress. This child becomes fearful or starts acting out. Okay, that stress that occurred, whatever it is, it could have been witnessing a murder, witnessing the murder of its parent. Maybe the child was sexually abused, physically abused, or something happened to the child. And within 3 months of that stressor, the child now either regresses, acts like a little child, or acts like a baby, like a toddler. It becomes fearful or starts acting out, doing things that it never did before. It would now start doing, screaming or crying or something like that, getting out of control. The stress temporarily overwhelms that child, and now it doesn't have the capacity to problem solve, and it results in impaired functioning. The child doesn't function like it used to. Now the child was going okay, all of a sudden, bam! Now this happens, and the whole demeanor, it changes. So that's how you could tell that this is an adjustment disorder. So basically, it requires understanding, support, and encouraging the child to move beyond the stressful event. Tourette syndrome, or tic disorder, okay? Basically, this is a persistent motor or vocal disorder where you will have the person either constantly saying the same phrase or word, like wooden nickel, wooden nickel, wooden nickel, and they'll say that, or they'll go they'll just say continuously, they'll say that, or they'll do grimace, like every maybe minute or so. They'll do that. Or they'll clap. They'll do that, okay? So it's non-rhythmic. The tick is quick and non-rhythmic movements or vocalization. They just happen over and over. It's not caused by anything neurologic, no substances, nothing like Huntington's disease or anything like that. So basically, that is what tick disorder is. So how do we manage it? Well, there's cognitive behavioral therapy, where we want to try to identify what is causing that person to do that, and can they identify when it's going to happen. And usually they can identify when it's going to happen. And so then, because of that, what we do is we use habit reversal training, which is doing the opposite movement or doing something opposite. As soon as you feel like it's going to happen, you do something different, the reverse. So if it's like, if my tick is that I move my head to the right, when I'm sensing that the tick is coming, I move it to the left. And eventually they say that it will neutralize the tick and reduce anxiety and reduce depression or whatever is causing it, okay? Also, there is an antipsychotic that you could use, Haldol or Risperidol. There's epilepsy medication and ADHD medication you could also use, okay? And that's, and for the hand clapping, instead of, when the person is going to clap their hands, what they should do is put their hands in their pockets. And for screaming, they should just, when they feel like they're going to scream, they should take a deep breath, and then it goes away, okay? Let's do intellectual disabilities. This is for people who are on the spectrum. And what is that? Well, that's when you have an intellectual quota or an IQ of approximately 7 or below. Now, when do we see this impairment? How do we see this impairment? Well, it usually is manifested in different areas of functioning. At least 2 areas it has to be in order to be an intellectual disability, either in area of communication, self-care, home living, social and interpersonal skills. The onset is usually before 18, and there's a YouTube video that I put up that you could watch in order to learn more about it. I thank you so much, and it's been a pleasure working with you guys. I really mean that from the bottom of my heart. I love you guys all, and God bless you, and I hope to see you in the nursing field one day. Bye.